about going to talk today about upper extremity repetitive strain injuries. And in the work comp world, repetitive is also simultaneous with cumulative. Cumulative trauma is the term often used. So what these are, what we're going to talk about is those injuries, sprains and strains that occur over a period of time. They're not acute injuries, but they tend to be cumulative. There's something in the workplace that is a stressor, generally physical, that produces the problem. And there are two aspects of this I want to discuss. One is I want to talk about the nature of some of these, the categories, and then even more important is the approach to the patient, because it's possible to kind of wander around making a diagnosis and then developing a treatment plan. So it's possible to have sort of a structured approach to this. And what we'll talk about is one way to do it. And if you have your own way to do it, that's fine. But it's the importance of having a plan relatively early on. So in terms of repetitive strain injuries, cumulative trauma, upper extremity, and this is generally elbows and distally, it's not shoulders. There are the tendinopathies, those conditions that have to do with abnormal or with tendon problems, neuropathies where there's a neuropathic problem. And then what, in my experience, is often the largest group or a significant group is just non-specific straining injuries that folks have when they come into the clinic. So these are what we're going to talk about. And then what I'd like to discuss is just how we go about evaluating these and what's the management, what's the organized management, structured management of proceeding with trying to resolve the problem. So here are a couple of thoughts to emphasize. One is at the outset, we really need to understand the injury. We need to ask enough to understand what's happened in the workplace that's causing the problem. And shortly thereafter, you want to develop a working diagnosis and differential diagnoses. We talked about this before, but the goal in medicine, and I think in our training, we often don't, there's not enough emphasis on really coming up with a working diagnosis, which is not a symptom or a sign. The working diagnosis isn't pain, it's something. It's what's the condition that's causing the problem that brings the patient in. So the diagnosis isn't what they complain about. The working diagnosis is what's the cause of the problem. And then the differential diagnoses are what other conditions might be the cause if what we think is the working diagnosis really proves not to be the case with as we're doing our evaluation. So then once we have a working diagnosis and plan, and we've got in the back of our minds differential diagnoses, have a plan that includes where you're going and the steps that you will take. Having a plan facilitates deciding what to do. If we continue to have our symptoms be our diagnosis, we're kind of wandering oftentimes. So having an actual working diagnosis facilitates deciding what we're going to do, how we're going to manage the problem. And it also enhances the likelihood that our requests will be approved in utilization review. We're much more likely, because authorization comes from our being consistent with medical treatment utilization schedule. Those are based on actual diagnoses. And if we're submitting a symptom as our diagnosis and then asking for some sort of procedure, there's less likelihood we're going to have our request approved because lack of specificity. So increases the likelihood of being approved if we have an actual working diagnosis. And finally, it also, frankly, gives the patient, the employer, and the adjuster the confidence you know what you're doing. When they ask you, doctor, what do you think my problem is? And if we say the diagnosis is pain, their response is, well, that's what I told you. Now, what is my problem? So we need to be thinking in terms of working diagnoses. So having said that, categories of tendinopathy, there's several. Epicondylitis, I think we're all familiar with this, lateral medial epicondyles. in the workplace. And incidentally, what we're saying applies not only to the work situation, but non-industrial. The approach to these, what the conditions are. We see these not infrequently in non-industrial conditions as well. So this isn't just a work comp discussion. So epicondylitis can be either lateral or medial epicondyles uncommonly, but possible both are involved with inflammatory changes causing pain. Tends to be oftentimes prolonged or repetitive forceful use or overexertion of forearm and wrist muscles, resulting in epicondylitis. Also, unaccustomed use, poor technique, improperly sized equipment that may contribute to the disorder. And particularly that latter is an issue of workplace ergonomics or other place ergonomics. The second category that we see, radial styloid tenosynovitis, also known as de Quervain's tenosynovitis. It's the tendon sheath that surrounds the abductor pollicis longus and extensor pollicis brevis tendons, so that there's tenderness at the area of the radial styloid, and with extension of the thumb, particularly against resistance, pain is increased. There's a complaint of increased pain. So this is a fairly specific problem. The challenge in repetitive injury is the pain there can radiate, and sometimes it's felt up the forearm and can mask as other things, but always has tenderness over the extensor sheath involving those two tendons. May be associated with repetitive grip, grasp, vibration with thumb and or wrist, radial deviation and extension. May occur with lifting or twisting, same kind of things as can produce epicondylitis. Increased frequency in individuals, interestingly, with a history of elbow, lateral and medial epicondylitis, which may be a compensatory problem, stressing the wrist if there's pain in the elbow. Trigger finger, not something that in the industrial world work comp occurs terribly commonly, but certainly can. Anatomically, it can involve any finger flexor tendon. It's not an extensor problem, that is to say a flexor tendon problem, extensor tendon problem. It's a flexor tendon problem. And most times the causes are unknown, but there are risk factors that predispose and can really be the cause, particularly rheumatoid arthritis, but also diabetes, hypothyroidism, sarcoidosis, amyloidosis, psoriatic arthritis, other collagen vascular problems. The challenge with trigger finger is oftentimes it shows up when people are working and is considered to be job related, but truth be told, some number of these are really don't have much to do with work, but the patient starts to feel the knot in the flexor tendon, which is tender, and then notices a trigger finger. There's a catching when they try and extend the finger, and it's recognized when they're using equipment. It may or may not be job related, but most of the time, it's going to end up being considered and managed as job related. Occupational risk factors may include repetitive forceful grip activity, force combined with repetition or awkward postures and vibration. So sometimes see this in folks that are doing computer data processing, but also in the construction trades. And then finally, our favorite, carpal tunnel syndrome. It involves, of course, pressure on the median nerve as it passes under the carpal tunnel, produces pain, numbness, tingling symptoms in the palmar side of the fingers, digits 2, 3, and the radial aspect of 4 can also involve the thumb. And it's caused by any condition that puts pressure on the median nerve in the carpal tunnel, and can be space occupying lesions, not very common. But it more commonly is swelling, particularly of tendons that exist in the carpal tunnel, but there's pressure on the median nerve. And of course, the treatment ends up being a decompression. Underlying conditions or comorbid conditions can increase the risk, diabetes, hypothyroid, obesity, and some inflammatory conditions as well. And a challenge, sometimes we'll get calls from carriers where we've diagnosed carpal tunnel, and there's a question about, well, the patient's got diabetes or hypothyroidism. Provider, do you think that that's really what's going on? And, it's really difficult to parse these. I think in most cases, what we would say is that some of these predispose to the condition. But if there's a history of repetitive manual activity, vibratory stress on the palm and wrist, something where there's an abnormal or prolonged activity involving the upper extremity, we end up considering it carpal tunnel. So sometimes hard to parse the various contributors, but generally ends up being accepted. Again, hand tool vibration may be a risk factor. Other proposed occupational risk factors include prolonged task duration, dominant hand overuse. So most of the ones that I think we see really have to do with use of a computer keyboard and mouse. So neuropathies, the other neuropathy besides carpal tunnel is ulnar neuropathy. Involves the ulnar nerve, which passes posteriorly in the anatomic position and then distally to the medial epicondyle. And pressure in that area, or actually anywhere along the ulnar nerve, can produce ulnar neuropathy. And but most of the time it's a problem in the elbow, not necessarily associated with medial epicondylitis. But what it produces, of course, is symptoms of what are called cubital tunnel syndrome, when it involves the elbow. It can also be a problem at the wrist. And then what we see is numbness, pain, tingling in the fifth finger and the ulnar aspect of the fourth finger on the involved side. So ulnar neuropathy, carpal tunnel syndrome are two neuropathies in addition to the three tendinopathies mentioned. And then finally, which is not uncommon, just the general non-specific chronic strains. Dorsal usually involves the dorsal aspect of the forearm, may involve the volar aspect as well. But there's a history of progressive onset most of the time of this sort of forearm pain. There may be numbness or tingling, but it's usually pain. And it's non-specific. And this is one of those cases where we just end up using the diagnostic term, not a repetitive strain injury, although that really applies to the conditions we're talking about as a general category. Now, what do we do with these? What happens when patients come into the clinic, they complain about, either from the job or otherwise, the sort of insidious onset of symptoms in the upper extremity, generally at the elbow or distally, may involve pain, numbness, tingling, weakness. And there really was no specific onset, no particular injurious event that occurred. How do we approach these? What do we do in terms of diagnosis, treatment, and what's the end point of this? Because some of these can go on for quite a while. Well, again, it's a matter of coming up with a working diagnosis and differential diagnosis. We're thinking about to start with a symptom because that's what the patient's telling us, or a physical finding. In the case of, for example, trigger finger, my finger catches, I can't extend it. But quickly, we want to come up to what we think a working diagnosis is. And relatively early in the history, we should be able to surmise what that would be. And then it's an issue also in work comp of trying to decide if the job is related to this. Do we think it's probable or certain, meaning 51% or more likelihood based upon however you quantitate that? Or is it just possible, which would be less than that? So when we think it's probable, then that becomes our working diagnosis, which of course a working diagnosis can change in the course of evaluation and management. It may look at the outset like a non-specific strain of the forearm, but along the way, it becomes clear that it's a carpal tunnel syndrome. So we need to be flexible, but we have a working diagnosis to start. In terms of the history, always need to have a sense of what the activity of the employee is, what were they doing when they first noticed it, if there was something that was specific, and what is it the injury that we think actually happened? What's the job description? What is it they do in the course of their work? Is it likely that what they're doing could lead to what they're talking about? And recall an early discussion we had to do with job causation. The decision we're making, the carriers ask us to make, is an AOE, COE decision arising out of and in the course of employment. And what that means is we need to determine that there's a causal relationship arising out of, there's a causal relationship. The work that they do could reasonably cause the problem with which they present. And there's a temporal relationship arising out of and in the course of. In the course of is the temporal relationship. Is there a reasonable time relationship between what they're describing and what's going on? For example, to deviate for a second on this, if they come in with carpal tunnel syndrome on the second day of the job, a new job, not terribly likely that that's really the cause, because the vast majority of carpal tunnel syndrome is a progressive cumulative problem. Just as a hernia, which is another example, but not in this discussion, but nevertheless something that tends to develop over time. So there needs to be a reasonable relation to work and a reasonable time relationship. And so third, we're asking, how long have you done this job? How long have you worked for the company? How long have you done this job? And then any pre-existing problems, always important. If they had this before, have they had anything like this before? Did they have it and it was treated and it went away? Did they have this problem, never went away, persisted, got better, and then now it's getting worse? And that'll influence what our decisions are about at least causal relationship to the job and a temporal relationship, and then how we manage it. So important is getting an accurate history about what has gone on. And then we take a more detailed history, and we are aware of the general symptomatic complaints. They come in and complain about pain or dysesthesia, some abnormal sensation, weakness, whatever the symptom is. And then what we need to do is be thinking about the conditions that can cause this, that might well be the explanation that will give us our working diagnosis. If it's a problem in the elbow, is it an epicondylitis? If it's in the wrist, might it be trigger finger or might it be radial styloid? Well, it wouldn't be a trigger finger, but might it be a carpal tunnel? Might it just be a non-specific strain? So we're trying to determine that as we take the history. As we do an exam, is there a change in sensation that's detectable? Is there a change in strength, one hand to the other? Is there a change in range of motion? And it gives us some idea about, are we talking about epicondylitis if there's tenderness over one or both epicondyles? Is there tenderness over the thumb extensor tendon sheath that would suggest radial styloid? Is there catching of the finger? This is pretty easy and not generally confused with other things. Carpal tunnel, are there physical findings that are consistent? Bearing in mind that Phelan and Tennell signs are notoriously difficult to elicit, and false positive, false negatives don't rule out or rule in the condition. And then is there just forearm tenderness that would suggest maybe we're just talking about a general forearm strain, but that can occur with these other conditions. So the exam should help us be more specific to me in terms of what our working diagnosis is. Then, if x-ray is available on that day, most of the time, whether it's the elbow or the wrist or the hand, getting an x-ray is a good idea, partly because in some cases it'll give us information about what we think the condition is, but most of those I mentioned don't have X-ray changes, but we look also for other changes, pre-existing problems, arthritic changes, evidence of prior trauma, some other abnormality. So X-rays can be useful in terms of excluding other not considered conditions or including those among our differential diagnosis. So most of the time we get an X-ray of the body part that's involved. And then neurodiagnostics, ultrasound and imaging to consider. Neurodiagnostics are going to be most valuable, in fact, diagnostic for carpal tunnel and ulnar neuropathy. The other value of that is when there's a possibility of a cervical neuropathy, radiculopathy, it will rule that out generally. Or if there's a peripheral neuropathy from some other condition, non-traumatic. And so it's worth getting EMG and nerve conduction velocity. And of course, you know that EMG gives us information about radiculopathy because it's testing, it's sampling muscles. And we know, the neurologist knows what cervical nerve roots make up the nerves that go to the various muscles. And nerve conduction velocity, primarily in the palm, gives us information about conduction, the speed of conduction of electric impulse through the median nerve. They're sampling the speed of conduction proximal and distal to the carpal tunnel. And if they're slowing the carpal tunnel, it's diagnostic of carpal tunnel syndrome. So neurodiagnostics are often valuable to help us determine. That isn't something typically we would do right away, but along the course of management evaluation, neurodiagnostics are of value. Ultrasound rarely ends up being useful. Sometimes if there's a specific case, wouldn't ever do ultrasound without a specific diagnosis. You need to use it looking for something. You need to have something in mind, an actual working diagnosis that you're trying to rule in or rule out. And so generally for repetitive strain injuries, upper extremity is of limited value, but occasionally is. MRI CT also similarly of limited value, but sometimes can be useful depending upon what's your working diagnosis, what's the specific condition you're trying to rule in or rule out. So you may choose to use imaging, but it needs to be specific for a particular working diagnosis. Now, how do you manage work status with these? Well, as you recall, what we're always trying to do is keep people at work whenever possible with restrictions. Sometimes that just isn't possible, excuse me, for some reason. So you have to use your judgment, but the default position is construct some sort of restrictions that then the employer can either accommodate or can't. And they'll make the decision as to whether the employee stays on the job. And the vast majority, certainly all 4 of those or 5 of those conditions I mentioned, as well as the non-specific, unless there's an unusual work situation, can be considered light work that can be provided. So this is one set of sentences that verbiage that can be applied, but use your own, whatever seems reasonable to you. But one approach would be avoid disable continuous repetitive manual tasks, alternate every 30 minutes on and off the computer, keyboard and mouse, take a stretch break for 5 minutes every 2 hours. The idea in any of the repetitive strain injuries is to break up the repetitive work. And so a thought is to accomplish perhaps half the workday doing the tasks, half the workday not. But that doesn't mean 4 hours of repetitive work in the morning and 4 hours of other things in the afternoon. It means during the course of an hour, breaking up repetitive tasks. And then other restrictions that are specific to their job and circumstance. So Each job is a little bit different. Many of the folks doing data processing is much the same, but if there's something about their job that requires some additional restriction, limitation, then you put it in. Medications, nonsteroidal anti-inflammatories, most of the time are beneficial. Muscle relaxants can be. For epicondylitis, medial or lateral, and certainly the lateral seems to be the more common, steroid injections relatively early on can be not only diagnostic but therapeutic. So if you're comfortable with those, and if you're not, call Bill Coggin or Dr. Pricey, or any of us are happy to talk to you about how to do them. But anyway, steroid injections at the epicondyle can be very useful if you're talking about epicondylitis. So consider that early on. Millie's probably an expert in this too. Therapy, occupational therapy in general, most therapists go up, proximal to the hand, go up to the elbow. Proximal to the elbow becomes the purview of the physical therapist. So most of the time, it's going to be occupational therapy that we're going to recommend for any of these conditions. So think about that, and think about that relatively early on. So I would really consider that. DME, wrist splitting for carpal tunnel, of course. Elbow straps for epicondylitis, and thumb spica splints if you're talking about radial tenosynovitis, decoy veins. I'm sure you're probably all familiar with thumb spica splints. I presume we have these in all the clinics, but that's one that immobilizes the thumb in extension, and can be really very helpful for folks that have got decoy veins. So be thinking early on in these conditions about appropriate DME. Ergonomic assessment of the workstation, really important. Some employers have their own internal people if they're large enough. Some will contract that out. Some physical therapists are available to do that. But I would really have ergonomic assessment of the workstation done sooner rather than later, particularly in those situations where there are folks that are doing data processing or some other seated repetitive activity. If they're a carpenter, that's a little tough. But the workstation, I would really consider if it's appropriate, and order that right away. And that's got to get authorized. It's got to get scheduled. So I would order that probably, if not on the first, at least on the second visit, the first follow-up visit. And then when do you get the specialists involved in these things? And that'll depend upon what the condition is. Orthopedic surgery, if there's epicondylitis, if you've gone through those things just heretofore listed, you've done a steroid injection, not any better, then it's the orthopod that we would end up referring to. Similarly, say surgery, and that would be hand surgery, specifically for radial tenosynovitis. Occasionally, if we just can't get them better with everything we've done, then the hand surgeon, if we can find one that'll see work come in the area. But when we've done all those things listed before, we haven't solved the problem, then it's orthopedic surgery. Physiatry, if it looks like, excuse me, it could be any of those, or forearm, any of the diagnoses mentioned, including forearm, kind of non-specific. And I distinguish physiatry from pain medicine. Most of the time, pain medicine are physiatrists. Sometimes they're anesthesiologists, but physiatrists are folks like Jesse Bernstein at Monterey Spine and Joint, who really, I think, doesn't want to deal so much with prolonged pain problems, but looking for things that can be fixed from a PM&R standpoint. So I list that separately from pain medicine, which is in our area a group like Comprehensive Spine and Sport, or Victor Lee, or one of the others that are doing pain and have various backgrounds. So we think about making referrals. So if you get to this point and those steps that you've taken haven't solved the problem, then it's time for the specialist. And frankly, early on, sometimes carpal tunnel, if you've gotten an EMG, nerve conduction studies, and you determine that there is a carpal tunnel, you've still gone through therapy, because most of the hand surgeons want that to be done first, then that's sometimes an earlier referral. And then when all's said and done, and nothing makes them better in the work comp world, but also in the group health world, we think about telling the patient, medicine's not a perfect science. There are occasions where we just can't make all things go away, and we need to recognize that this may be present for a while. And so when all appropriate care has either been offered or performed, and it appears that no material change in symptoms and signs will change in the next 12 months, this is out of the labor code, the patient's considered to having achieved maximal medical improvement and it is permanent stationary. Maximal medical improvement, of course, you recall, is the provider's observation that we just aren't going to be able to likely improve their condition in the next 12 months. And then the administrative term is permanent stationary. And what happens then is the active claim is concluded, but as we recommend, we may do a PR4 and recommend future medical care, then that can be provided for the patient. Or this is also the patient where surgery would be indicated in carpal tunnel, but the patient just doesn't want to have it done right now, or in the foreseeable future, and will want to have provision for future care for that. This is a situation where the change just isn't otherwise not likely to change in the next 12 months. We call them MMI and determine them PNS, send in a PR4, and just provide for future medical care to include future surgery. So in work comp, there's a starting point. We're making a diagnosis. We're making a working diagnosis. We're first determining something's job related, making a working diagnosis, determining a plan, following the course that it works for you. What I've described here works. You may have some other way you go about it, but come up with a plan and then let the patient know along the way where you are in the course of the plan. I usually tell folks at the outset, this is what we're going to do, depending upon how you respond. And then when you get to the end of it, if they've recovered, great, that's what you want. If they haven't recovered, if they still got a problem, then they understand what you've done, and they are maybe more accepting of a condition that isn't going to go away right now, but there's provision for future care. So job relationship, make a working diagnosis, work with a working diagnosis, not a symptom. Go through your plan that you've established at the outset, and then get to the end point, whatever that is.